Good morning, everyone. Today, our IC topic is troubles in topography. So, as the diagnosis and the diagnostic tools are increasing in the world, we are making diagnosis, and there are less chances that we are misdiagnosing the things and making complication and avoiding complications. So, through this, I see this course to provide a comprehensive understanding of corneal topography. Throughout this IC, we will explore the principles and application of corneal topography, including its role in the diagnosing corneal condition, planning refractive surgery, and fitting contact lenses. So we'll start with our first speaker, Dr. Kanika Bharadwaj. Her topic is From Placido Platforms to Scheimpflug Scanners, Topography's Best Kept Secrets.
No, ये नहीं है. Please upload my slides, Dr. Kanika. Yes. Thank you. Very good morning, everyone. And today we are here to discuss about topography. But before delving into the deeper secrets, we should also know where this topography actually started from. So as they say, to better comprehend the present and to better plan the future, one should always have a knowledge of the history. And today I'll be taking you through the history from Placido's platforms to Scheimpflug scanners, how topography has evolved and what have been the secrets to its development. I have no financial interests. So the tales of topography actually started to exist out of necessity, a necessity to understand better the surface of the eye for diagnosing, vision correction, and surgery. And as they say, the true creator is necessity, who is the mother of invention. Therefore, when the necessity to study the surface arises, that's when invention started to happen. The idea had not reached the final destination right from the beginning. It evolved as a simple observation, and based on that, various devices were and logics were applied to come to the conclusion of how to map the corneal surface. So it was a simple observation, and which now developed into a technology-driven, sophisticated imaging system. So the term topography itself, it is combined of two Greek words, topos and graphia. Topos means place and graphia means description. As the name suggests, it is the description of a place. In our context, we can say it is the description of a surface. Originally, topography was referred to geographical locations, that is, studying of the peaks and troughs occurring on the Earth's surface. But when scientists observed that cornea itself resembles somewhat like the Earth's surface, that's when topography was applied to cornea as well. So we can imagine that cornea behaves like the earth of the eye, the window to the soul. Just like the earth holds the life, topography maps actually resemble the terrain maps of the earth. So if we see geographical mapping patterns, they have these steep areas marked in red and flatter areas close to the sea level marked in blue and lighter colors. It's from there, the color coding of the corneal topography was derived. So the study of corneal shape has undergone significant advancements, and like I said before, it was a simple observation that led to this change. Scheiner in early 17th century noticed the reflection of marbles. Anybody who knows marbles, Hindi mein kanche bolte hain. So the marble's reflection on corneal surface prompted Scheiner to study the corneal surface. And that's how the concept of corneal surface mapping came into being. So what was the origin of corneal topography? It had a humble beginning from a Placido disc, and with advancement today we are here with the modern machines which have artificial intelligence incorporated to them. So 1880s marked the birth of corneal topography. This was a milestone in the history of topography because here we had the development of Placido's disc. Placido disc was invented by an Italian ophthalmologist, Antonio Placido, and it was a simple tool. It consisted of a black and white concentric ring marked surface which was reflected off the cornea. So initially, it was non-illuminated. It was just a board having concentric black and white rings which were projected onto the cornea with the illumination in the background. Later, things got modified, and the shape and spacing of these reflected rings gave an idea of how the corneal curvature was. So in a normally symmetric cornea, aspheric cornea, we can see all the rings are equally spaced and in gradual progression from center to periphery. Whereas in astigmatism, whether it is with the rule or irregular, we can see how the pattern shifts where the steepness is there. So you can consider this like a corneal volcano. The peak of the volcano signifies where all the rings get concentrated. So what is the utility of Placido disc? So from being just a single two-dimensional device, it converted to a keratoscope. Placido disc devices are sometimes also called in basic terms as keratoscope. So kerato refers to the cornea, scopy means reading of the structure. So Placido disc was incorporated into a handheld illuminated device which was known as keratoscope. It is still used today even in the modern tools. The Placido component is also present in the modern topographers. It is not the only way to measure the corneal topography, but it aids or it supplements in the data collection. Intraoperatively also, Placido principle can be applied to study astigmatism, especially in cases of corneal pathologies post-penetrating keratoplasty. The diagram here shows a Maloney keratometer. It's a simple device with multiple rings etched onto it, which is placed under the microscope on the cornea, and it shows us intraoperatively whether the wound correction is properly symmetrical in all directions. So here we can see post-penetrating keratoplasty just to identify if all the sutures are holding the same tension all around. The central ring is completely spherical. So this gives an idea. If this was an oval or shifted somewhere, we would know where the tight sutures are and we can remove and replace the sutures. So intraoperatively also this plays a very important role. Now let's have some fun fact. Not just in cornea or geographical mapping, the principle of these striations or concentric rings or lines is also utilized in the automobile industry. As we can see here, this is a reflecting surface consisting of alternate black and white lines. And you know where this is used? This is used to identify hidden dents on the surface of automobiles. So if you see, here we can see the pattern is straight, but the area where the dent is, which is not appreciable because of the thick paint coatings, but can be appreciated with the help of these reflector sheets. So this is one thing where we can use the same principle to identify deformities in the surface in the day-to-day life. Now, after the 1800s, once the Placido disc was invented, definitely corneal mapping and study became a little bit better, but it was still not ideal. So then enters photography. Now, whatever image reflections were seen were tried to capture on a photographic image platform. So that's when photokeratoscopy came into being. And this added, of course, more precision and allowed for more manual measurement of corneal curvature and therefore better planning of surgical incisions or lenses or even corneal procedures. Thus, photokeratoscope was born and they could measure curvature more accurately, but it was time consuming and because it was manual, it was not immune to errors, I would say. So this was the original photokeratoscope that was invented. As we can see, it has a Placido disc platform. Now, during the 1950s, there was an observation that this Placido disc, when projected onto the cornea, was not able to properly identify the peripheral curved part of the cornea. That's when the concept of a curved platform came, and from a flat surface, it was a curve. So if you would have noticed in the modern day combined topographers, the Placido disc is placed in the form of a curved platform because it tends to capture even the periphery of the cornea. As we all know, cornea is prolate in shape. It is not entirely spherical. It gets flatter towards the periphery. So after the 1980s came the generation of the digital leap, and we got computers, a boon to the modern society. And that's when the photokeratoscopy also became computerized. So the concept of single picture evolved from a picture to a video-based format, that is collection of a series of pictures and combining it into the form of a video, and therefore better assessing the anatomy and the surface. So video keratoscopes were actually cameras which captured the ring reflections and transferred the data to the computers where the analysis was done, and the final 3D image plotting for the cornea was done. So these devices digitize the reflection of rings and use software to reconstruct a color-coded map. Now this was where the color-coded mapping technique came into being. So prior to this, the Placido disc could only tell us where the imperfections were, but the color coding map, which is hotter colors for the steeper areas and cooler colors for the flatter areas, they started to develop late in the 1980s. Systems like keratograph and TMS, which is topographic modeling system, came into use. There are other examples also, like even in modern day topography, we find pure topographers such as Atlas and Nidex Scan. So now that everything was good, then what was missing? Why did we search for more? Firstly, all these topographers or the Placido disc-based imaging techniques, they were limited to the anterior cornea. And we know that anterior cornea alone is not responsible for majority of the corneal pathologies or even presentation, such as keratoconus, which is primarily a disease of the posterior part of the cornea. Video keratoscopes relied on reflected images. Therefore, it was also dependent on the tear film that was present. Any irregularity in the tear film would affect the reflections and therefore the quality of the interpretation. And they only captured data from the front. They were not truly 3D because the videos were merged. The videos used to merge various 2D photographs. So it was not entirely a proper 3D model, but an extrapolated one. There was no option of pachymetry or corneal thickness mapping, and we could also not assess the anterior chamber. It was dependent on surface quality. Any scarring or corneal pathology, even as small thing as a dry spot, could alter the results. So video keratoscopes, even though were essential in the 1980s and 90s, they laid the groundwork for modern mapping, but they just weren't the final destination. They were more like a stepping stone in the journey. Now came 1990s. Now enters the scanning slit topography. So with the thought process that came that we need to see the depth of the cornea and even the anterior segment and the thickness of the cornea, scanning slit techniques were incorporated to topography. That is, we made a thin slit which would scan the cornea microscopically. It was like an optical section, and multiple such optical sections will then be combined with the help of Placido disc to come up with a more naturally resembling corneal surface map. So the idea was to project a slit of light like a thin laser beam. Now this could be presented in various configurations, horizontal, vertical, in a 360-degree format, and therefore a combined pattern would be generated. The camera would capture the cross-sectional silhouette and of the cornea as well as the slit, and by scanning multiple slices, a 3D model would be reconstructed. Now this was a turning stone in topography. Another fun fact, slit scanning is also used in cinematography, where people want to create unique time-based images. So you can see when there is a slit image scanning, we can create time deficit in between, and therefore it is also utilized in modern-day cinematography. So the key device that held the flag for this slit scan and Placido combined topography was the OBSCAN. The OBSCAN 1 was only slit scan, but OBSCAN 2 combined the Placido also. So this was invented in 1997 and 99. It was developed by Bosch and Lamb in collaboration with Optech. OBSCAN 1 and 2 were the first commercial scanning slit tomographers, and they were very successful during their time because it was another milestone in the journey. They had Placido disc integration, which combined the curvature as well as the elevation. And it became widely used for refractive surgery screening, even corneal diagnosis, pre- and post-LASIK workup and analysis. But there were limitations to the scanning slit technology as well. So what were the limitations? Even though it was born from the need to see inside, not just the surface, It introduced the first practical way to measure posterior surface, but modern topography was beyond this. It had a few weaknesses such as light scatter, which affected the accuracy in the opaque or edematous corneas. So the light could not penetrate through the opaque corneas, and therefore the scattering would degrade the quality of results. It was slightly less precise as compared to a Scheimpflug or an OCT image for posterior cornea measurements. Still, it marked the first true attempt at full volume corneal analysis. Then came a fortunate occurrence. So the person in the picture is Theodor Scheimpflug. The Scheimpflug principle is after his name. He was actually an Austrian military engineer, not an ophthalmologist. And Scheimpflug, during his working tenure, he noticed that whenever he tried to take pictures, he was a military engineer and an aircraft operator. So when in sky, when he would take pictures, he noticed that the pictures would not be very clear because of the dimensional changes and the tilting. So that's when he wanted to solve the problem of tilted planes. What he did was he devised a method to keep an entire tilted object in focus, which is called the Scheimpflug principle. So this is the camera that he invented. So according to the Scheimpflug principle, what happens when the lens plane, the image plane, and the subject plane, when intercepted from all distances but converge at a single point, the stability or the entire scene, it stayed in sharp focus. So that's how it was actually devised for aerospace engineering and for terrain mapping. But scientists eventually started to compare the surface of cornea with the surface of Earth and realized that cornea and lens also have the same problems because of the shape similarities and the difference. So optical engineers realized that the curved transparent eye surface also have imaging challenges similar to that faced from an aerial view. And that's why Scheimpflug principle was incorporated into the corneal topography. And as a matter of fact, the first Scheimpflug device was not used to measure the cornea. It was used to measure the lens using the lens opacity grading system. So in 1990s and 2000s, the elevation mapping and tomography came. Now the concept here was to go beyond the surface curvature. So in the late 20th century, engineers saw the potential in Scheimpflug, and they tried to capture cross-sectional images of the curved surfaces. They also tried to maintain focus through the entire depth of cornea. Oculus was the company that came forward and did pioneer work, and Oculus developed the instrument using Scheimpflug camera for the anterior segment of the eye, which we fondly know today as pentacam, and it is an indispensable tool in modern-day topography and planning. So the concept from surface was to go beyond the surface, to go beneath the anterior segment. A star was born. Pentacam by Oculus became a game changer. It provided high-resolution 3D imaging of both anterior and posterior corneal surfaces and also measured corneal thickness. So why is it called pentacam? I'm sure most of you must have asked this question to yourself once in your lifetime. Why was it named pentacam? Penta signifies 5, and the name pentacam comes from its core imaging principle, which has 5 data sets. So the 5 data sets that are captured are actually anterior corneal surface, posterior corneal surface, the corneal thickness or the pachymetry, the anterior chamber depth, and lens and iris imaging. So because of these 5 data sets, it was called pentacam. There's also a notion that in the early designs, the penta also referred to the idea of capturing 5 different meridians or 5 image planes through a camera that rotates 360 degrees around the optical axis to build a 3D model. So why is Scheimpflug so valuable? So unlike the traditional reflective techniques like Placido disc, Scheimpflug imaging does not rely on corneal reflection. So any imperfections in the cornea will not alter the imaging or the result received. Secondly, it can image the back surface of the cornea. This was again a milestone because the back surface of the cornea holds so much information that was not utilized previously. It offers depth data and not just curvature, and it helps diagnose diseases such as keratoconus, post-LASIK ectasia, and more, which were more important in the clinical practice. Scheimpflug imaging made it possible to see the eye not just as a surface, but as a volume, and it revolutionized the diagnosis, screening, and surgical precision. I don't have any financial interests. 2010s were the time when the modern day topography came into being. Now, modern day topography also includes the artificial intelligence and ultra precision techniques. So these are smart and integrated systems. They have very high resolution. They cross-validate results by utilizing multiple methods in the same device, and they create more robust, accurate 3D models. We can also include AI-based diagnostic algorithms, and we can map and even predict the occurrence of diseases very early in these. Most of them are also able to do wavefront aberrometry, tear film analysis, AI-assisted detections, and integration with LASIK planning. Some examples of these ultra-modern topographers are Galilei, Topolizer, Vario, Sirius, Cassini, and Pentacam AXL. Now, today's technical stack that we say, today's present times modern topographers, they are multimodal devices. Just like a multitasking woman, they have all things in one. For example, the Placido disc technology, it gives us high curvature resolution. Scheimpflug gives a good 3D elevation and anterior segment depth. OCT in some models can give us micron level posterior epithelial layer mapping. And wavefront aberrometry can include optical quality and high order aberrations. And AI algorithm can give us risk scoring and even data prediction and pattern recognition. The presently used modern devices, there are many, but we can restrict ourselves to the most popular ones. The Oculus Pentacam AXL, which includes Scheimpflug as well as axial length feature. Zimmer Galilei G6, which has dual Scheimpflug plus Placido, and also gives us aerial calculations. The CSO Sirius, which gives us Scheimpflug plus Placido. Nidec OPD Scan 3, which gives us topography and wavefront aberrometry. And CSO MS39, which gives us spectral domain OCT along with Placido and epithelial mapping. So most of these newer devices combine a lot of things together, and they are not just topographers. Fun fact, Corneal maps are now helping design personalized optics for augmented reality lenses, and your eye's unique terrain could actually shape the screens of the future. Just like fingerprints, corneal topography is unique. Even identical twins do not have the same corneal topography, and that is why the more advanced security, biometric security systems nowadays are utilizing corneal topography in some part of the world to utilize the uniqueness. To conclude, I would say corneal topography started to exist when optics, medicine, and technology converged, and beginning with a simple, humble disc, it has now evolved into a core tool of the modern eye care. Topography today is not just surface mapping, it's a diagnostic window into the entire front of the eye. Thank you.
Thank you, Dr. Kanika. So if we have any question, can we save it for the end of the session? And if there is important question regarding to Dr. Kanika's talk, we can have few questions right now as well. So as she mentioned that we are very advanced as far as corneal diagnostics are concerned, but we're still looking forward for the device which can help us to map the cornea, which is scarred or which is post-surgical cornea. So still there's a lot of space for the newer devices, though we are dealing with a lot of diagnostic tools which are ultra modern, but we're looking forward to the new device which can help in such situations. Thank you. So our next speaker, Dr. Garvita Dabas, she's going to speak on the topic, peeking through the pages, navigating Pentacam, Galilei, and Cirrus reports.
Thank you, ma'am. Can I have my slide, please? Right. Not this one. Top one, sir. Right. So, welcome to my talk. It's peeking through the pages, navigating Pentacam, Galilei, and Cirrus reports. In my presentation, I would like to highlight the 3 available Scheimpflug camera-based devices, which is the Pentacam Oculus, Galilei by Zimmer, and Sirius by CSO. I would like to go in detail as much as I can within the 15 minutes allotted to me, and I apologize in advance because it's a very theoretical topic, so I would like to cover available topographic markers in all of the platforms. So beginning with the topographers, there are 3 available topographers. The principal includes for the Pentacam is single Scheimpflug image, Galilee includes dual Scheimpflug with Placido, and Sirius with single Scheimpflug with Placido disk. The acquisition speed remains 25 scan images per 2 seconds. Galilee, it increases to 25 to 50 scan images in 2 seconds, and Sirius again 25 scan in 2 seconds. Points mapped are mentioned 25,000 in Pentacam, 1,22,000 points in Galilee, and in Sirius we have 21,632 anterior and 16,000 posterior elevation points. So discussing the topography indices of first Pentacam, we have the most important BAD-D map, which is a multivariate index. It includes anterior elevation, posterior elevation, and even the pachymetric elevation. So technically what BAD-D does, it compares your available patient's retina with the best fit sphere, which is calculated in the optical zone of 8 mm, and the enhanced reference surface is determined with the central 8 mm zone. So as you see in the images, I have attached available Pentacam images. This is the elevation back, this is the elevation front. This is the mapping, and this is the difference map that is the most commonly seen by the surgeons. And the red spots, the yellow spots, and the green spots, these are all in comparison to the best fit sphere. The other available markers, as I have mentioned in this slide, the blue box, which is the CTSP, corneal thickness spatial profile, it represents progressive thickening of the cornea from the thinnest point to the periphery along these concentric rings, and the percentage of increase is marked by the box given below, the red box, the percentage thickness index. So the Bellin-Ambrosio Enhanced Ectasia report reports 5 indexes, which is DF, which is changes in the anterior elevation from standard BSF to the enhanced reference surface, which is DF front, given by the first red box in this purple box. The first red box is DF. Secondly, there is changes in the posterior elevation given by DB, which is D back. The third marker is DP, pachymetric progression, which is the comparison of corneal thickness at the thinnest point. Finally, the fourth is DT, which is the thinnest point of displacement. And finally, pachymetric progression, which is DA, and it compares the thinnest displacement. The final D value is achieved by all the 5 parameters, and it is a linear regression analysis from the standard database as comparing to a keratoconus cornea. Let's focus on the pachymetric progression index, which is suggested by this green box. Yes, so it calculates the change in corneal thickness all over the 360 degrees of cornea. The progression value at each meridia is compared from the thinnest point, which is defined as the progression index, and the average of all is determined by PPI average, which is the average value. So the PPI max and min, these are 2 values that are available here. There's a general confusion, so I want to just clear that PPI max is the maximal pachymetric increase and PPI min is the minimal pachymetric increase. So the rapidity with which this PPI changes is increased in ectatic cornea, which identifies it and settles it apart from the normal cornea. Coming to the next indices, which is the Ambrosio relational thickness, ART max, ART min, and ART average. So these are all validated diagnostic indexes. Finally, the ISV, which is the index surface variance, it is measured as the standard deviation of individual sagittal radii as compared to the mean curvature. So basically, it is a marker of surface irregularity, and it is increased in patients with ectatic disorders like keratoconus. So it is a very sensitive index, and if ISV is more than 37, it generally comes up with a yellow mark depending on the color settings of the Pentacam, and if it's more than 41, it's a red mark and it's considered a pathological marker. Finally, coming to the index of vertical asymmetry, IVA, it is the second marker in this chart. So IVA is expressed in value, and it is the mean difference between the superior corneal curvature and the inferior corneal curvature, and the level of curvature symmetry with respect to the horizontal medium. So more than 0.28 is abnormal, and more than 0.32 is pathological. As is given in the picture, 0.61 is marked with a red color. Keratoconus index Ki is again the ratio between the upper and lower half of the cornea. The Ki more than 1.07 is pathological. CKI refers to only the central keratoconus index. More than 1.03, as is this particular value, is considered abnormal or pathological. Finally, the index of height asymmetry, IHA, the above marker, is expressed in micrometer, and it's the mean difference between the corneal elevation in the superior hemisphere as compared to the inferior hemisphere. More than 19 is abnormal, and more than 21 is absolutely pathological. The index of height decentration measures the vertical decentration as compared with the Fourier analysis, and more than 0.014 is abnormal, and more than 0.06 is pathological. Finally, coming to R min, which is the smallest radius of sagittal or axial corneal curvature, it denotes the steepness of the cornea, so that is less than 6.71 is abnormal or pathological. Coming to now the serious topographer, the most important value is RMS value, which is the root mean square, and it is defined as the deviation in the regularity or aberrations as compared to the spherotoric surface. Unlike the pentacam, where we take the best fit sphere, this compares a spherotoric surface. So RMS by A, basically it's the root mean square per area. The lower the value, that is the more regular the cornea, and higher the value, that is more irregular the cornea. Followed by RMSF, which is the front value, RMSF upon A, which is calculated on the anterior surface. The cutoff value for that is 0.88, as mentioned here, and keratoconus is 0.13. Finally, for the back surface, a keratoconus suspect can have a value of 0.212, and KC patient generally have value more than 267. Coming to symmetry index of curvature, as given in this chart, SIF, SIB. So basically, symmetric index of curvature refers to the difference in the tangential curvature, again expressed in diopters, between two circular zones, as given in this diagram. These are the two circular zones, X and Y values, and their radius is generally 1.5 mm. So for the front surface, SIF, it measures the vertical asymmetry. So positive values means inferior surface is more steeper than the superior, which is why if it's a negative value, that means the negative value suggests superior surface is more steeper than the inferior surface. Again, the back surface, SIB, is again expressed in diopters. It again has the opposite sign because it is also comparable to the SIF. Coming to the next marker, which is keratoconus vertex front and back, KV. It is again a comparison of highest point of ectasia on the anterior and the posterior elevation map, respectively. And finally, the Baichi-Kelosi-Versace front and back index, we call it BCV, front and back, which is basically an analysis of the aberrometry, like the coma and trefoil components of the Zernike polynomials, and comparing the index of BCV and vectorial BCV, it gives us a vectorial sum of BCV front and back. In the Galilei topographer, the final topographer, I want to mention the asphericity asymmetric index, AAI, also called as the Kranemann arc index. It indicates asymmetry in the asphericity of cornea. Posterior AAI and anterior AAI are both seen, and posterior AAI should be less than 20 to 25 microns. The center and surround index, CSI, is a quantitative index, and the lower the value, that means normal cornea, regular astigmatism, and higher the value, it suggests keratoconus or ectatic cornea. Finally, the differential sector index, it describes the degree of asymmetry present on the corneal surface. The corneal surface is again divided into 8 sectors, almost 45 degrees each, and the maximum difference between the two sectors, that is called DSI, which is the differential sector index. The cutoff value for detecting keratoconus is 3.26, and whereas detecting pre-keratoconus is 1.73. This is a Galilee topography map. We will now cover the corneal shape asymmetry, which is the KPI, K, and PPK values. These are the Zernike polynomials that, as mentioned here, the coma and trefoil that we had compared previously. The opposite sector index, again, the same sectors which are created with a 45-degree angle. So the OSI, which is the opposite sector index, is a screening index for keratoconus, but it does not perform well for the pre-keratoconus cornea. The cutoff for keratoconus detection is 2.04. The surface regularity index, again, if it's 0, it implies the corneal surface is completely smooth. And if it increases and there is an irregularity with a value of more than 1.55, it suggests ectatic changes. Irregular astigmatism index, again, describes variation in axial power, and it is an excellent marker for keratoconus. Surface asymmetry index is again a good marker for keratoconus, and it is the best parameter to distinguish between clinical KC in all of the Galilee indices. Coming to KPI, which is the keratoconus prediction index, it is the percentage probability of keratoconus by analyzing the topography data. The parameters that are included in KPI calculation include simulated keratometry, CSI, DSI, OSI, SAI, II, and percentage area analyzed. So KPI may be 0 to 10%, which is normal cornea. KPI of 20 to 30 suspicious cornea, and more than 30% can indicate PMD or other ectatic disorders. Finally, the cone location and magnitude index, CLMIA, as given here. It is the magnitude that represents difference between the steepest area from the remainder of curvature map. Keratoconus probability is characterized by sensitivity and specificity of the KPI. So cutoff value of K probability more than 25.5 is for clinical keratoconus and 11.60 for subclinical pre-keratoconus. Finally, the percentage probability of keratoconus, the clinical KC may be 45% and pre-keratoconus may be 20%. So if we compare all the parameters across all the 3 platforms, generally the Bellin-Ambrosio system of enhanced ectasia, and especially the ISV on Pentacam, they are statistically similar to the 4.5 mm RMS area of the Sirius and the keratoconus prediction index and the keratoconus probability on Galilei. So either of the machines that any surgeon may have, they perform all well. However, one point to be noted here, the Pentacam, Galilei, and Sirius all show accuracy on repeated measurements. However, the repeatability is much better on Pentacam and Sirius as compared to the Galilei, as per the available literature reports. So finally, I hope I did some justice to all the topography parameters, and there are multiple topography devices, and all of them serve an excellent function of detecting and highlighting ectatic diseases. And however, with each surgeon, every topographer, their repeatability and comparing indices across the topographer, that will help us in the long-term management of keratoconus. Thank you.
Thank you, Dr. Garvita. If you have any questions for the speaker. Okay. So our next topic would be on the borderline cornea. So we are going to, I'm going to cover the topic that how to deal with borderline cornea if we need to plan some surgeries. So okay. So the topic is aptly decided, mapping the margins and sculpting the borderline corneas. So why we are covering this topic? Because corneal ectasia is a sight-threatening complication of keratorefractive surgery, which is characterized by progressive steepening and thinning of the cornea. And this is the most dreadful complication any surgeon can expect. Why? Because it gives you irregular astigmatism, loss of best-corrected visual acuity, it can present day to year after the procedure, and the prevalence is theoretically low, estimated between 0.04 to zero point 0.6. But are we underestimating or we understating the problem? So through this presentation, I'm going to cover a few more aspects of it. Post-LASIK ectasia is clinically important for two aspects. First of all, the condition is preventable. If we take a wise decision, we can avoid this situation, and mostly LASIK patients are young adults in whom the burden of condition is greater. So what is a safe threshold? Can anyone decide that? So the question asked by the surgeons, what is a borderline cornea? How thin is too thin? And how thick should the cornea to maintain the structural integrity? And how deep can the surgeon go? Why do some patients with abnormal topographies not develop ectasia following keratorefractive surgery, while some patients with normal looking eyes do? So these are the questions which I would like to answer through this presentation. Another thing which is very important to understand are thin corneas an independent risk factor for post-LASIK ectasia. Suppose patient come to you and you feel the cornea is thin. So will that person definitely have ectasia after refractive surgery? The answer is, it is not an independent indicator. Corneal thickness alone is not a measure of cornea's inherent structural stability. Crosslink corneas are stronger, stiffer, and more impact, though they are thinner. And keratoconus can be seen even in the eyes with thick corneas. So the pachymetry is not the only independent risk factor we have to understand before we start doing refractive surgery. What are the red flags? Abnormal shape size, that means curvature and diameter. Pachymetry, of course. Comorbidities like autoimmune disorders like rheumatoid arthritis. And scarred cornea, maybe post-RK and the post-viral keratitis or any other kind of scarring. So what determines successful refractive surgery outcome? First of all, a patient selection is the first and foremost, a careful history, a detailed informed consent about the risk and benefit, and the meticulous preoperative testing, which we all do. And these are the tests we all do before screening for the refractive surgery. So relevant factor in refractive surgery screening are, which are non-alterable, we call them intrinsic biomechanical properties. For example, corneal topography, which you cannot alter, it is there. It is genetic, the person is born with that. And the second thing is age. Alterable biomechanical factors are percentage tissue altered and residual stromal bed. I'm going to cover each factor independently. So these factors which are non-alterable, they are mostly the base for the ectasia scoring system. So why the age important? If the patient is less than 22, then there's a higher risk of ectasia because the patient is still growing and the keratoconus might develop later as well, and we might miss that. And higher risk of unstable refraction, if the refraction is not stable and you do the surgery, then it's a risk factor. And the higher risk of non-compliance, which I don't agree with, but yeah, literature says that. Then the older patient who are more than 40, their presbyopia may not allow glass independence, may have to consider monovision, lenticular status may make the keratorefractive surgery moot, and often have other ocular comorbidities. So the very important factor is residual stromal bed. So do you know any magic number that this is the residual bed I want in my patient? And every surgeon will answer, no. There is no magic number. Literature is full of numbers, but it is depending upon the different studies. So what I follow, that whatever cornea you have to customize your treatment as per cornea. So your RSB should not be less than 50% of the original corneal thickness. You can correct only that much refractive error, which will not alter more than 50% of original cornea, since the structural support for the cornea has been shown to reside in anterior cornea. For example, if the pre-surgery pachymetry is 546, post-ablation RSB should be more than 273. Whatever literature say that 250 is okay, 230 is okay, no. you have to calculate 50% as per patient. So each surgeon must develop his or her own safety limit for the RSB, but this should not be less than 300. Modern literature says that, but literature is full of the number between 250 to 300. I follow that I should not go below 300. Percent tissue altered. So the principle is how preoperative corneal thickness combined with excimer laser ablation translates into postoperative corneal biomechanics. So PTA matrix representing the percentage of anterior corneal tissue that is modified during refractive surgery. The PTA takes into account the integrated relationship between preoperative corneal thickness, ablation depth, flap thickness, and final RSB. And we calculate it like this. This is the formula for calculating PTA. So flap thickness plus ablation depth divided by central corneal thickness. It should be less than 40%. You should not select patients who are more than 40%. Independent indicator for the postoperative corneal ectasia risk, and the PTA should more than 40% the negative prognostic indicator. So let's discuss some clinical scenario where these are the borderline corneas where I'm going to present, and where the surgeon was confused at what decision to take and what option to give to the patient. So this clinical scenario, a 32-year-old woman present with a LASIK consultation with the hopes of being less dependent on her glasses. She does not wear any contact lenses. The external examination revealed excellent exposure with a corneal diameter of 10 millimeter, and the anterior segment evaluation is normal, and the fundus is normal. So this is her refractive screening. It looks very uneventful except for few challenges which I'm going to discuss in the next slide. So my challenges in this patient: relatively steep curvature, small corneal diameter, that is 10 millimeter, thin pachymetry, that is 504 and 507, and the large pupil size. So the shape is a challenge, the size is a challenge, and the thickness is a challenge. If we calculate the RSB, that is 326 and 333, which is more than 50% of the central corneal thickness, and the PTA is 35.2 and 34.2. If we see the RSB, we are going to interfere with more than 50% of anterior cornea, though the PTA is coming out to be normal. So can we decrease the RSB? Like, can we relieve more RSB for the patient? So we have to decide what procedure to do. So these are the surgical options given to the patient, but my limitation with the microkeratome LASIK was flap diameter is dependent on corneal curvature and the diameter. The flap must be large enough to accommodate the large treatment zone, yet so large that it extends into limbus. Since the corneal diameter is smaller, and with the large diameter treatment zone, I can reach the limbus and it can bleed. A slight flap decentration, there is a significant risk of limbal invasion and the hemorrhage, which we never want during surgery. In femtolasic, can I decide for the femtolasic or any lenticule surgery? We can, because it is independent of corneal curvature and diameter. And limitation or centration is a concern. Since the diameter is small, the flap edge close to the limbus, limbal bleeding, and anterior chamber air bubble also the chances. PRK, no flap-related risk. A large zone with an added blend can be done, and excellent centration should not be difficult to achieve. The only limitation is regression in age with that kind of refractive error. Now, the third option is, can we go for the faking implant? So yeah, the cost and the intraoperative complication. So patient decided to go for the PRK and looks fine. The RSB is 434, and 439, which is more than 50% of the cornea, and patient is happy. So the take-off message after this case is, recognize the special challenges posted by the patient with microcornea. Surface ablation remain an important keratorefractive option in selected cases. The femtosecond laser is safer than microkeratome in patient with small, steep cornea because it offers more control over the flap diameter. So let's discuss the second scenario. In this, the 25-year-old woman, RGP user for 11 years, she tolerates the contact lenses for 14 to 16 hours daily. The lens power has not changed in last 2 years. She was asked to leave her contact lenses out before the examination, but she didn't have any glasses to wear and so wore the contact up to the time for her examination. So microscopic examination revealed 1 to 2 millimeter superficial vascularization in both corneas, consistent with her long-term contact lens wear. Corneal diameter is 11 millimeter horizontally, which looks fine. The rest of her examination is normal and the eyelid fissure appear adequate for the microkeratome suction ring. And this is a refractive screening. So it's a high myopia with cylindrical error, and if we see the pachymetry is 515 and 517, the only red flag in this refractive screening is the topography. It's a mild inferior steepening, OU, correspond to keratometry and refraction, posterior deviation are normal. So we see the abnormal curvature map, but our elevation maps are absolutely normal. So I decided the challenge was, will there be an adequate stromal tissue for the laser ablation since the refractive error is around 10, I'll show the spherical equivalent, to correct this amount of myopia and astigmatism. With spherical equivalent of -10 and 9.5, a conventional laser procedure can be estimated to remove 120 micron and 114 micron to provide complete correction. RSB is 285 and 293, which is more than 50% of the central corneal thickness. And the PTA is coming out to be 44.6 and 43.3. The corneal topography show inferior steepening along with somewhat high K reading and slightly thin pachymetry. So it called for the critical evaluation for subclinical keratoconus. Since the refractive error was very stable, so this come in my mind that is it a contact lens molding or the warpage. So I asked the patient not to wear contact lens for 3 weeks and come to me again. And then the topography showed nearly complete resolution of the inferior steepening and no inferior thinning on pachymetry. Slit lamp examination was unchanged. Refractive error was unchanged. So yeah, sometimes the curvature map does not give you the real story. And if the patient is contact lens user, we should always have a contact lens free time and then do the topography again. So for this patient, the concern was keratorefractive procedure. Why I don't want to do keratorefractive procedure in this patient? Because borderline stromal thickness for laser vision correction. PTA is more than 40%, which is a risk for post-op ectasia. Future enhancement not possible without enough corneal stroma. And, So yeah, the treatment plan was phakic lens implant and the BCV was 20/25, no night vision problem noted. So the message is the differentiation of the subclinical keratoconus from contact lens induced corneal warpage is important for both accurate surgical correction and safety. Phakic IOL implantation is a good option to discuss with patients who have any suggestion of FFKC on their preoperative topography. And phakic IOL produce equivalent or the superior vision for patients with inadequate or borderline stromal thickness for the laser vision correction. So as Dr. Garvita also covered regarding the topography and tomography, and Dr. Kanika also covered that how we evolved from topography to tomography. So sometime when we see only curvature map, we make wrong decision. So we have to see elevation map, pachymetry map, and curvature map in toto, and then only decide whether we are dealing with the abnormal keratometry or we are dealing with some factors like keratoconus warpage. Now, the third clinical scenario, it's the last clinical scenario which I have for you, is a 30-year-old Asian woman was interested in refractive surgery. She had worn contact lenses for 10 years and had been out of them for 3 weeks. The pulpal fissure was small and the lids were somewhat tight. The corneal diameter was 11, IOP was 12 in both eyes, and slit lamp and fundus examination were completely normal. This is a refractive screening, and this has a mixed astigmatism. And the pachymetry is 502 and 506. Topography in the next slide here. So my challenges with this topography was, it's a relatively thin pachymetry, increased risk of night vision problem with high astigmatism, and the pachymetry map reveals the thinnest portion of the cornea to be displaced inferotemporal in the right eye and slightly displaced inferotemporal in the left eye. Yeah, so displaced pachymetric maps. So what were the examination in favor? The BCV was 20/20, the stable refraction for 2 years, normal curvature and elevation map, normal Bellin abrasio enhanced ectasia screening, and RSB was 353 and 343, which are more than 50% of CCT, and the PTA was 29.6 and 32.1. The pachymetry curves follow the mean and standard deviation curves, indicating that corneal pachymetry increases appropriately as one progresses from thinnest portion of the cornea to the periphery. So only one factor will not decide whether the patient is unfit. Every other things were normal. It can be the decentered map, it can be the decentered pachymetry map. anything can happen, but we have to see other factors as well before denying a surgery to the patient, because patient has very high refractive error and the glass independent is something they are looking for. So we should be very well versed with the diagnostic tools so that we can say yes and no to the patient. So the pachymetry finding alone are not sufficient for the surgeon to reject the patient as a candidate for the refractive error. The treatment plan was patient opted for PRK, though it is a little higher refractive error. We explained about the haze and regression, and we have RSV about 458 and 457, which means that patient has it is more than 50% of CCT. So the thin pachymetry, tight lid, small purple fissure, small corneal diameter, PRK seemed to be the better option for better than LASIK. And the post-op vision was good. So careful analysis of corneal topography, power, and the elevation thickness is especially important in highly astigmatic patient to rule out sign of pre-existing ectasia. And highly astigmatic patient should be presented with realistic vision expectation and warned about the possible night visual symptoms. Successful correction of high astigmatism has the potential to improve near as well as distance vision even in the young patient. So the conclusion is clinician must never rely solely on one measurement or the data point in determining the patient's suitability for corneal refractive surgery or ectasia risk. Nevertheless, the improved screening protocol, enhanced understanding of corneal biomechanics, judicious application of patient selection criteria, we can strive to reduce the incidence of post-operative ectasia as much as possible. Crucial is to understand the problem, recognize the problem, accepting its risk factor, critical towards achieving the significant reduction in occurrence of this adverse event. Thank you very much for your patience. I'm open for any questions. And if you have decided something else for these patients, maybe my decisions are different from you, I'm open for all the feedbacks. Thank you very much for listening to me.
Thank you, ma'am, and that was very informative along with the examples. I would now like to invite Dr. Kritika. She will cover the topic of topography's glimpse into touched up corneas. I spy with my little eye.
Good afternoon, everyone. So today, once we have walked through the tomography's basics, let's go ahead with the tomography's glimpse into touched-up corneas. I have no financial interest. So what do I mean by touched-up corneas in this context? I mean to say those post-laser vision correction surgery, post-pterygium excision surgery, post-corneal cross-linking surgery, could be post-ICRS, that is intracorneal ring segment placement surgery, or could be a post-keratoplasty case, or the use of tomography in calculation of intraocular lens power in post-corneal surgery patients. In case of a post-laser vision correction surgery, post-refractive surgery, tomography is crucial in assessing and managing patients undergoing refractive surgery both pre- and post-operatively. How? Because laser vision correction changes the total keratometric power due to the changes that the refractive surgery makes in the anterior corneal surface. That is, the keratometric index from the standard value of 1.3375 gets variable post-refractive surgery. It is usually 1.332. Post-laser vision correction surgery, tomography aids in monitoring the outcomes, in diagnosis and management of complications like decentered ablation, like retained lenticule, like laser enhancement surgery, and for diagnosis of post-laser vision correction ectasia. Few of the parameters we should be looking into while looking at the tomography scan are: first, look at the Q value that indicates the asphericity of cornea. So what is Q value? Normal Q value is from minus 0.10 to minus 0.30, that is towards a prolate shift. Oblate is towards a positive asphericity and prolate is showing a negative asphericity, as we can see in the picture aside. So next we should be looking into is a keratometry value, either steepening or flattening. Steepening usually is post-hyperopic correction, and flattening of keratometry is usually post-myopic ablation surgeries. Next, we should look on to pachymetry at thinnest location, and do not forget, look at the quad map and balance map. Before we jump on to the tomography scans, let's have a quick revision about what we spoke just now. So look at the Q value. A positive asphericity means it is usually a post-myopic laser vision correction surgery. Could be a keratoconic eye as well. A negative asphericity means post-hyperopic laser vision correction surgery. Steeper and thinner corneas on curvature maps are represented by warm colors, whereas flatter and thicker corneas are represented on curvature maps as cool colors. So this is our first tomography scan. The scan on the left-hand side is of a preoperative one, and the one on the right-hand side is post-operative one. As we can see the colors, the color has changed from warmer color to a cooler color, from green to bluer ones, with keratometry values in the map also showing flattening values. When we look at the indices of this tomography scan, from preoperative value of Q value of minus 0.38, the value has changed to plus 0.45. There is a shift towards positive side. That is, it is going into a positive asphericity. That is, it's a oblate cornea, which is further confirmed by the keratometry values. That is, it has changed from 4142 to 38 post-operatively. Posterior corneal values remain unchanged, and there is a reduction in the thickness of cornea. So this is a case of post-myopic laser vision correction surgery. Moving on to the next scan, the preoperative scan and the post-operative scan change in color depicts that it has changed from cooler colors to warmer colors. That is from yellow to amber side. And the keratometry values also shows steepening. When we look at the indices of this scan, Q value has changed from minus 0.27 to minus 0.85. That is, it is going to a negative shift. That is, it's going into a prolate cornea, which means further proven by keratometry indices by 45 preoperatively to 47, 48 postoperatively. Posterior corneal values remain unchanged, and there is a reduction in the thickness of cornea. So this is a post-hyperopic ablation. So the next tomography scan, when we look into the indices first, preoperative and postoperative values, Q value has changed slightly from minus 0.35 to minus 0.43. That is a slight negative asphericity shift towards a prolate cornea again, and the keratometry values shows steepening from 4142 preoperatively to 43 postoperatively. Posterior corneal values remain unchanged, and there is reduction in corneal thickness. When we look into the maps, when we look into the pentacam map, that is the tomography map of this patient, what we can see here is there is change of cooler color to a warmer color. The cooler color, that is the green color, has changed to a warmer color on one quadrant and to a cooler color on the other quadrant. But as this could be a case of ectasia as well, but when we look at the corresponding maps, there is no steepening seen. Though there is increase in thickness, though there is elevation seen on elevation map, there is no thinning seen on the corresponding area on pachymetry map. So this is not a case of ectasia. So what could this be? When we looked into clinical picture of this patient, this was actually a referred case. So when we looked into the clinical picture of this case, this patient was a post-calyx procedure wherein there was a decentered corneal ablation, plus patient had a retained lenticule, which was further proven on AIOS2025 scan showing a hyperreflective tissue that is as seen in this, in the interface area. So this is a case of retained lenticule. As discussed, this patient, apart from one diagnosis of retained lenticule, also has another, that is a decentered ablation. That is, the ablation pattern has moved beyond the pupillary axis. The pupillary region is a dotted circle that is seen here. The ablation pattern is right here and it's right here. Another scan of decentered ablation again. So moving ahead with the next scan, this is the preoperative indices, postoperative indices. From Q value of 0.46, minus 0.46, there is a shift towards plus 0.24, going towards a positive asphericity, that is an oblate shift. Hence, keratometry values also shows a flattening effect from 4142 to 39 postoperatively. Posterior corneal values, when we look at this pattern, the K1 value from 5.9 has slightly increased to 6.3. Other values have remained unchanged. And there is thinning of the cornea, reduction in thickness of cornea postoperatively. So this was the tomography scan when 2017 preoperatively, 2024 postoperatively. This patient showed a slight elevation seen in the inferior quadrant with a corresponding thinning as well, and elevation on elevation maps. So this is a case of post-laser vision correction ectasia. Moving on to our further surgeries. As we all know, pterygium usually induces a witherul astigmatism, which leads to visual distortion and decreased visual acuity. So how does it affect? This is one of the scan curvature maps showing serial curvature maps of an eye with grade 3 nasal pterygium. When we look at this scans, so preoperatively, this was the scan showing a flattening effect on the nasal side. Postoperatively, 6 months postoperatively, this patient has shown a very good improvement, that there is no flattening effect seen. And also, the astigmatism has changed from 5.7 diopters preoperatively to 0.6 diopters postoperatively. Hence, we can see two things in the scan, that is steepening of the flat meridian, and there is a decrease in the corneal astigmatism. Corneal tomography, specifically in a case of pterygium, is important because it takes into account the corneal periphery as well, just not like the keratometry value. So moving ahead to the further surgery, post-corneal cross-linking. As we all know, corneal cross-linking is performed in a case of corneal ectasia. On tomography, post-corneal cross-linking, how it sees is, there is decrease in maximum curvature of cornea, there is increase in minimum radius, there is reduction in corneal thickness, and tomography post-corneal cross-linking is done to monitor progression of ectasia. So this is one pentacam, wherein preoperatively, as we can see in this case, this is the same scan where I had prior shown about the post-LASIK ectasia. So this patient was taken up for INTAX, that is ICRS, intracorneal ring segment surgery. Post-surgery, we can see the steepened area has regularized. So this is a post-ICRS implantation scan. So post-ICRS implantation, it flattens and regularizes the cornea as shown prior. It improves the uncorrected and corrected visual acuity. It delays or prevents a need for keratoplasty. On tomography, as discussed prior, it flattens the anterior corneal surface. The Q value shifts towards the oblate side. There'll be decrease in keratometry values, and it is done to monitor progression of ectasia. In a case of post-keratoplasty, the most commonly performed procedures, that is penetrating keratoplasty and deep anterior lamellar keratoplasty, the most commonly performed worldwide, success of whom just depends not only just on the corneal clarity, but also on the post-operative induced astigmatism and higher order aberrations. How? The tomography is used to evaluate and manage post-keratoplasty astigmatism. The astigmatism can be managed by spectacles or contact lenses, by doing a post-operative suture manipulation, which is most commonly practiced, by putting compression sutures, by putting relaxing incisions, by going for a laser vision correction surgery post-operatively, or by doing a ICRS insertion or placement of intraocular lens, or ultimately doing a regrafting itself. So as told before, post-operative suture manipulation is done either by adjusting the tension in running sutures or selectively removing the interrupted sutures. Selective suture removal on one quadrant, that is a steeper quadrant, flattens the corresponding semimeridian, which is shown in this picture. The curvature map of this image on the left-hand side is a 7 months post-penetrating keratoplasty image, wherein there is a induced 11.7 diopter of astigmatism has been induced. As we can see, on this axis, it is 50.8 of keratometry power, whereas in the vertical axis, it is somewhere around 34. So when selective suture removal of sutures was done at 3 o'clock and 9 o'clock, there is a steeper cornea, what happened 3 months post-operatively, post-suture removal, is that the astigmatism drastically reduced from 11.7 diopters preoperatively to 3.9 diopters post-suture release, giving a very good visual acuity of 0.1 logmer with minus 1.75 spear and plus 3 cell. So this gives us the importance of tomography scan in suture removal as well post-keratoplasty. Last but not the least, tomography is very important when it comes to calculation of accurate intraocular lens power. As we all know, IOL power calculation relies mainly on 3 main parameters: axial length, keratometry values, and anterior chamber depth. An error, a slightest error in any of these three parameters can end us up in refractive surprises, which we all don't want. Tomography measured corneal power has been found to improve the accuracy of IL power calculation. How? Just an example. This is a post-radial keratotomy scan. I just want to show highlight two important things in this case. One, look at the irregular astigmatism induced. And when we look at the indices, anterior corneal values have flattened to a very big extent. Also, the posterior corneal values changes in a post-radial keratotomy case. So moving ahead, how does it help in intraocular, how does tomography help in calculation of intraocular lens power is, we get a program in our tomographies, we get either TrueNet K power, we get total corneal refractive power, that is the TCRP, or we might enter the equivalent K readings, that is the EKR, either in 4.5 millimeter zone, or we can take a 3 millimeter zone. 3 millimeter zone is chosen for post-LASIK corneas, post-regularized corneas, whereas in case of post-archeo or post-keratoplasty, we can take a 4.5 mm zone. And we can enter the K value that we get from these formulas into the IOL Master 700, or we can enter straight away into ASRS or APACRS calculator available online and get a accurate IOL power for that eye. So few of the take-home messages. Tomography is used to monitor corneal changes. It is used to evaluate surgical outcome. Tomography is invaluable in early detection of post-operative complications. Tomography post-corneal surgery is a vital tool to ensure optimal outcomes and prevent potential issues. Thank you. Any questions, please?
Thank you, Dr. Kritika. So we would like to conclude our session with this talk, but we are open for any questions and any feedbacks.
As far as the bad D is concerned on Berlin Ambrosio, is there any significance of that 2.0? It is said that if it is more than 2, the refractive surgery should be considered with caution.
So you're talking about the final D value?
Yeah.
So if you have heard about, like if you heard the talk of even Balin and Dr. Ambrosio as well, he will also say that the one factor is not an indicator. So we have to see that why this 2 is coming. Is it from the DF, DB, DP? Because if you see the study and the normative data is not from Asian countries, if you ask me. So what happens, Asians have very thin cornea. So sometime when we scan those India, like in India only, we have like 503 cornea, and then the D value come out to be more than 2 standard deviation down. So then it's only because of pachymetry and all other factors are normal, then that D value has no importance. Though we always keep such patient as a suspect if the age is less than 21, women of childbearing age, or the fluctuating refraction. So then we keep them as a suspect and we try to follow them up in 6 months. But if the person is 25-year-old male, refraction is stable, then that one factor will not decide or reject the patient for refractive surgery.
Also, doctor, you can choose to go for the better corneal preservation techniques amongst the refractive surgeries also. If there's any doubt, we can definitely shift to surface ablation techniques, which give us a more safety margin in such cases. The best way, as ma'am told, would be to wait for some time and reassess and see how the parameters change. Like what ma'am said correctly, there are sometimes corneal cell swelling changes that can happen due to contact lenses or hormonal fluctuations as well. So it's better to repeat the test, give proper lubrication, improve the surface and call back the patient. And later on, if still there's a doubt, you can go for the preservation techniques, the surface ablation ones.
So anyways, the surface ablation techniques is very successful in the keratoconus patient as well. So we are doing surface ablation in the ectasia patient as well. So if you have to do the surgery where there's not a clear indicator of any ectasia, but the patient has high refractive error, you want to operate, then the PRK is the best option, or the phakic IOL, if the refraction is stable.
Where surface ablation is not...
Ma'am, you are not audible to me.
So PRK is not advisable and ICL is advisable in which cases?
Ma'am, you're talking about the journal exclusion criteria for PRK?
Yeah, okay.
The cornea which is not good for keratorefractive surgery, we cannot do even PRK in that cases. For example, if your corneal thickness is less than 470, so that is the standard when we don't touch the cornea. Less than 4, if you're talking about the refractive surgery. So PRK we do as a corneal regularization in the keratoconus patient as well. So if we keep that aside and we're just talking about the refractive surgery, then PRK is not advisable when your thickness will go down below 470. If the cornea is 460, 465 or 450, then, and even if it has physiological thin cornea, no ectasia sign, we don't do surgery in such patients. And all other patients where the LASIK is okay, PRK is definitely okay. Any other questions? Thank you for your patience. We would like to conclude our session with this.
Girls, you can come on top. We can click a picture. Come.